Good evening, everyone, and thank you for joining us. This webinar has been organised by the National Institute for Health and Care Research, known as the NIHR. NIHR funds, enables and delivers world-leading health and social care research that improves people's health and well-being and promotes economic growth. My name is Mark Layton. I'm a consultant haematologist at Imperial College Healthcare NHS Trust, and I'll be moderating tonight. I'm joined by my colleagues, Dr. Stephen Okoli, a consultant haematologist, a colleague of mine at Imperial, and Dr. Noemi Roy, Associate Professor of Molecular Haematology at the University of Oxford. We're also joined by two research participants, Funmi Desolu and Robert Ogier, who will speak about their first-hand experience of taking part in research. If you'd like to know more about taking part in research, please search Be Part of Research on Google to be directed to the NIHR Be Part of Research website. There you can find out about opportunities to take part in research across a wide range of conditions, including sickle cell. Today's webinar is being recorded and a subtitled video of it will be posted on the NIHR's YouTube channel, NIHR TV, after the event. We're aiming to finish around 8:30 tonight, but may run over a bit if the discussion is still taking place. To get us underway, I'd like to invite research participant Funmi to share her experience of being a sickle cell patient who is taking part in research.
Good evening, everyone. My name's Funmi. Bit of a background, so I'm a learning disability nurse and also currently doing a pre-doctoral research fellowship, which is just a fancy way of saying I'm doing a master's in clinical research. So I live with sickle cell and I'm currently part of the REDRESS trial. So REDRESS is basically a clinical trial that offers people with a matched sibling donor the chance of having a stem cell transplant. So I guess you sign up to the trial and you get randomized, which means you get either put into one group, which is standard of care, i.e. continue as you are, and another group is treatment group, which is transplant group. So I guess, why did I sign up to participate? I think there's been a couple of years now where I've been really, really keen for a cure. So when my medical team presented the option to me, it sounded great in theory, but I had to go away and took a lot of time to kind of think things through and really understand what I was signing up for. So mainly it was because I wanted a cure. But then I guess there was also the opportunity to kind of participate in sickle research and maybe improving things for others. So I guess those were like my main motivations about why I wanted to participate. What I was worried about, to be honest, I'm more of a person with an anxious disposition. I was worried about everything, to be quite frank. So I think for me, what was really important was that I had all of the information laid out before me. So I knew, okay, what exactly I'm getting involved in. What does this trial actually mean? What's going to happen if I do get this transplant? What is post-op care like? What do I expect, 10, 20 years down the line if I do get a transplant? So I think the whole process for me felt, I guess, quite daunting. But I think the research team were quite good. They were patient. They talked things through with me as and when needed. There was no feeling pressured or rushed to make a decision at a particular point in time. So I very much felt in control of the whole process. I had lots of questions. I remember writing down a list of about 50 different questions just to kind of give you guys a bit of an insight into where my brain was at. But I think it was just very important for me to kind of be aware. I kind of didn't want to walk into the process and suddenly surprises happen along the way. So eventually, after a series of tests, so they kind of do like a series of tests to check that you're healthy and fit enough to be part of the trial. I eventually found out what group I was in. So it turned out I was randomized to standard of care, which means continue as you are. And I can't lie, I was bummed. I was very, very upset. because obviously you sign up to a clinical trial because you want to be in a treatment arm, right? You want to have a transplant. And so I guess not being in the transplant group was hard to digest. It took me a couple of weeks to kind of process it and kind of get over it. But hindsight is a beautiful thing. If I had known what I know now, or known that I wasn't going to be in a transplant group, I would have signed up, because it goes back to actually sickle cell is a condition that affects me, affects many people that I care and love. And I think actually, if we look at the research landscape and we compare it to other conditions that are similarly inherited, there is a great disparity. Like, research in sickle is nowhere near where it should be. And I think that me personally, as someone who lives with the condition, has, I guess, some sort of onus, some sort of responsibility to kind of change things and improve things for patients. So I guess, yeah, I'm not in the transplant group, but actually my hope is still being part of this trial, I will help in terms of future treatment for people, better healthcare experiences for people along the way. So yeah, if anyone has any questions, very happy to answer.
Thanks very much, Funmi. I know you've got to leave around 7:30, so we'll take any questions directed towards you first. Can I bring in Stephen and Noemi just to say a little bit about the research trial and how their experience has been of running that particular trial, where not all participants necessarily will receive the intervention, in this case, a bone marrow transplant.
So, shall I go first? I just want to say, for me, that was a really well put together summary of where a lot of patients that I interact with regarding transplant, particularly this trial, are, because they want a curative option. They want something that's going to cure them of sickle. Who wouldn't? But also, this is a disorder that affects children, family, and they want to do something that's positive for sickle. So we have recruited several patients to the study. We've been exceptionally fortunate in Imperial that every single one of them has, kind of rubbing salt into the wound, but for all of them have been randomized to the transplant. So we're really fortunate in that. And I think your list of questions, there's slightly the 50 questions, so I'm sure Noemi was in there with you for a good length of time. What we try and do is we try and make sure that patients have an opportunity to ask questions. This is a massive entailment. This is not something that I want patients to take lightly, because it is a massive commitment. And you come into hospital as a sickle cell patient in a completely different environment than you would be otherwise. And that all needs to be worked through. We tell patients that this is a significant commitment, weeks, months, to get yourself to the point where you're going to receive your transplant, and then several months to get yourself out at the other end. So all of those bits need to be worked through very slowly. All the various tests, as you talked about, will be done. And then we get you to meet the transplant team, because they're the people that are going to be looking after you, taking the lead on your care during that hopefully that transplant period. So we get you to meet them, and then from there, process is very slow. I think very importantly, we also get you to meet some extended members of our team, the psychologist and the social worker. Those are two critical members of the team, because this is a very different psychological challenge than the really important challenges of sickle cell patients you already face. But I think that's probably where I'll stop, because I don't want to sort of take too much of the time. But yeah, it's a great chance, great option for our patients, but one that isn't taken lightly.
Thanks, Stephen. Noemi, do you want to?
Yeah, sure. So we don't have redress here in Oxford. So any of our patients that are interested, we send them to another centre. We have a different clinical trial, which is a tablet. It's called Hibiscus, and this is randomized again, but this time it's a tablet. So the patients don't know if they're having the real drug or if they're having a placebo. So it's a little bit easier because if you're, like in Fumi's case, if you're randomized to standard of care, you know that because you're not getting the transplant. Whereas if you're receiving a tablet treatment and you're randomized, the tablet looks the same. You don't know what it would look like. So patients do find it a little bit easier. The advantage as well of this trial is that if at the end of the year, the trial is unblinded, which is the name for finding out. So this trial is double blinded, which means neither the patients nor us, the doctors looking after the patients, know if the patient's having the real drug or the placebo. But at the end of the year, when it's unblinded, if the patient was having placebo, they're allowed to then have access to the drug, and so that's really great. But yes, I think I'm always very humbled by people who agree to join clinical trials. I think it's human nature, isn't it, to want to wait a bit until other people have had it so that you know if it's safe, if it works, etc. But then, of course, we wouldn't have new drugs if we didn't have people who were happy to volunteer and to take that risk. And obviously taking that risk, you might get something great because you might get really early access to a fantastic new drug, but obviously you might get either some bad side effects or you might get the placebo. So really everybody who joins research, and at the moment we're just talking about clinical trials, but there's also other types of research that we can go into, but everybody who joins research, they're really contributing to that scientific and medical advance.
Thanks, Naomi. Funmi, can I ask you, and I think I know the answer from what you've said, but did you feel you had enough time to reflect and decide to participate in the study, and how did that work in practice? Because normally you go to the clinic and you'd see your hematologist there and discuss treatment options and perhaps make a decision one way or another in favor of one particular treatment. But how did that differ from the process in a research trial setting?
Thank you, Mark. So I guess for me, my experience, I would say one thing I would like to say is actually this is not an overnight thing, like signing up to a clinical trial, especially one that involves transplant. It's not you blink or you wake up and yeah, I'm getting the transplant. No, this is a process. And it's very much something you have to take step by step and day by day. Going back to Mark's question, so I remember like we discussed it in clinic. I went away, I thought about it, had some questions, went back to the team to ask them the questions. Then eventually I saw the transplant team and they explained what exactly the trial was, what it involves. They gave me the patient information sheet. I had a read through that. Again, I had another opportunity to write down questions. So that first meeting with the transplant team was in person. And then we did a number of consultations online because I don't live in London, but I was referred to a London hospital. And then I decided to proceed, and then I had some in-person appointments. I think like ideally, you agree to the trial and then the next thing is you consent to the trial. I think for me, my consent journey took a little bit longer than expected, just because I had more questions and I was going back and forth and like, I'm not really sure if I want to do this. What happens if I do get the transplant? So I guess it goes back to like me saying you have to take things one step at a time. But I think it's important for people to know that there is no rush. There is no one that's pressuring you into making a particular decision. You can change your mind. You can say no at any particular point. So yeah, it looks different for every person. But I think, yeah, the most important thing is that you're comfortable and you're able to kind of have that peace of mind of I've been able to reach a decision that's right for me. Mark, hopefully that answers your question.
Yeah, thanks. So you didn't feel you were rushed at all at any stage. And I guess one of the fundamental principles of clinical research is the option for participants to opt out at any stage, even after starting a clinical trial. That's always open to them if they change their mind for any reason.
Yeah, completely.
I don't know if we've got any further questions in the Q&A.
We did have one question submitted. I think, Stephen, you were going to reply about that blood transfusion question.
Yeah, so what I can recall there was basically a question about from someone who's living with sickle, asking about their options, basically. So I think this person was, or maybe still is, on a transfusion program for their sickle cell, and unfortunately has started to develop antibodies. So the antibodies make it more difficult to get appropriate blood so that the transfusions are safe. I think in their case, they were asking about what could be done about that, and sort of, God forbid, they get to the point where they become untransfusible because they've developed so many antibodies. Now, obviously, we can't really talk about individual cases in this environment, but I think really what we would want to talk about is in the context of clinical research, several things. The first is that the whole benefit of research is to develop new treatments, and I think it's a shame that we're in a situation in 2025 where the cornerstone, the gold treatment for sickle is transfusions, and we need to develop new treatments, and clinical trials are the only way we're going to be able to do that. The second thing is there are research projects that have been set up in the UK to try and see how we can better obtain blood for patients, particularly given that the blood that patients receive in the UK is not ethnically matched to the people who donate the blood. So we know that the disparity is the vast majority of patients who are Black with sickle, and the vast majority of donors aren't. We tend to see more antibody development. Now, that is a call for all of us to try and donate blood, all of us who are able, to try and limit that risk. But there is a project called Heme Match that is trying to match blood to the patients who are receiving it, and hopefully limit these sorts of problems. I think that's really it, really. I think the focus is on trying to limit these antibodies, and by developing better treatments, really. Fortunately, there's a great deal you can do when people start to develop antibodies. It's really just to try and match the blood as appropriately as possible. But that's really all I could say on the matter. Then if anyone else wants to chip in.
Thanks, Stephen. No, Amy, I was interested. You were talking about the randomized control trials, and that presents a dilemma to patients participating in research, because it implies they might not necessarily get the active treatment. Increasing number of clinical trials do include the possibility of crossing over to the active drug, though, don't they now? So that if you are randomized to standard of care and don't receive the active drug and are found to be on placebo, but the active drug is effective, then there's very often an opportunity to receive that at some point during the trial. So that's another potential benefit for patients.
Yes, and that seems only fair, isn't it? I think, Ben, you wanted to say something. I think Robert's arrived, hasn't he?
That was exactly what I was going to say, Naomi, yes.
Fantastic. Mark or
Sorry,
Stephen,
guys.
you want to introduce Robert?
Yes. So I'm very pleased to welcome Robert, who's a participant in research at our own institution. And I don't know if Robert can hear me all right now, but we wondered if it would be possible for you to just give a brief description of your involvement and how it all went for you.
Sure. So, sorry, I'm late, guys. I literally was a technical difficulty. I really do apologize. But yeah, so my name's Robert Ogier. I'm a patient at Hammersmith Hospital, and about, I want to say, middle of last year, I was approached to inform me about the trial that's going on with the stem cell transplant, but it was a haplo transplant, so it's not a full match. And after speaking for a while with Dr. Okoli, who's one of the clinical hematologists at Hammersmith, he was put me forward. He was like, "Yeah, I think it'd be a very good idea," because I've been in and out of hospital quite frequently over the last couple of years, and with conditions not getting any much better really, even after increasing like the rate of having blood transfusions and yeah, so it wasn't getting much better. I was told about the trial that was going on, and yeah, so I signed up. I was like, well, I felt that it's interesting for one, and two, if I did get selected, which luckily I found out at the beginning of this year I was selected for the stem cell transplant. And yeah, so at the moment it's been a long stretch really, since way back when I heard about it to now, where I've done all the scans, the bone scans, the lung function tests, all the rest of it. And yeah, I'm here. So I'm waiting for, hopefully, we're hoping for the early next year, sort of, to start the transplant. And yeah, so that's where I'm at now. So it's very exciting, and I'm looking forward to it.
Thanks very much, Robert. Funmi was telling us earlier about the fact that she wasn't randomized to receive a transplant, but still saw benefits in participation in research. And I just wondered if you could sort of give a view on that. If you hadn't been randomized to receive a transplant, how you would have felt about it.
I still would have known me. I definitely would have signed up for it and agreed, because again, if you don't try, you don't know, right? And on top of it, I feel that as the transplants go ahead and more get done, I feel that, and as the results get better and the dramatic effect of people's lives change, I feel that eventually, hopefully, it'll be a service that the NHS will offer and roll out to everybody. So even if I didn't get randomized, I'll still definitely be championing it, because it's something that it may not be right now, but it's only a matter of time before it gets rolled out. And so even if you don't, I feel like it's difficult, we now being approved, to look back and be like, well, if I didn't, how would I feel? But at the same time, there's hope. And it may not be right this second, but just know it's coming. So prepare yourself and try to keep as well. Obviously, it's not easy to keep healthy and keep well, but just know that it will happen. I believe anyway, personally. So yeah, I think that's how I feel. And yeah.
Thanks. There's some sort of common themes emerging there. Stephen, Noemi, do you want to say anything?
Well, again, I would say, Robert, you missed what I said earlier, but I think for me as a doctor looking after people with sickle cell, I'm extremely grateful and humbled by people like you who go ahead and join these trials. I know you see it as a positive thing for you that you might access this treatment, but it is a risk you're taking, and it is just amazing that people are willing to go for it, because otherwise we would not ever have new treatments. So it's really wonderful. And of course, I keep saying it's a risk, but it's a risk not to do anything as well, right? So, but it's just, how do you weigh those things up, and how do you as a person make those decisions? I guess I was wondering, Robert, because I don't know you and I do know Funmi, is that Funmi spoke a little bit about the time it took her to make the decision. I mean, did you make the decision on your own? Was this something you discussed with your family? Yeah, go ahead.
No, definitely, it was a family decision to a certain extent. However, it was mad. I guess it was almost a child inside of me that made the decision for me, if I can put it that way, because it's something that, even being young, because so I'm one of four, so I've got two older sisters and one younger brother, and it was something that even going back to childhood, always wanted to be like them, be able to do everything they could do. So when this thing when it came about, and just hearing about it, it took me back to that moment of being a child wanting to be these. And I feel like this is as close as I've ever been, really, to be like my siblings in one way. But at the same time, I did have to talk to the family. It was a big decision, because at the same time, you go in looking at the positives, and I'm not saying you don't think about the recovery or how long the actual procedure, but at the same time, I was lucky to have a family that knows quite a lot and was quite knowledgeable, to be able to sit down and talk it through, with, even though my own selfish sort of wanting, it was the overall, I think it was definitely a deciding factor. But I feel that not only, yes, it's going to be difficult in the short term, but I feel like long term here, it will, the effect, I can't even put it into words. You can't really explain it, if that makes sense. So
That's fair enough. That's fair enough.
I'm trying, but I can't even think. It's just literally. But at the same time, yeah, it wasn't easy. I think that as I've gotten on, and since I've been approved to now, I feel that there's a lot more thinking about what it entails, what the actual process is, the risks are, and those sort of things. However, I think for me, I think the overriding thing was mainly the outside of hospital, because I understand that you guys do an amazing job when it comes to looking after sickle cell patients in hospital and making sure it tries to keep us out of hospital. But it was just the day-to-day living and those sort of changes that I wouldn't know. It's like a whole new thing for me. So it's just, that's the main, where my head's been at for most of it, really. So I think that was that was what it took to get to the decision I made before coming to the decision. And again, you guys did that. Dr. Okoli did help me talk it through. And
Fantastic, thank you. I noticed there's something in the chat. Ben, is that why you're raising your hand, to alert us to the chat?
It is, yes.
I can read your mind, Jen. Ben, I can read your mind.
Yeah, absolutely.
Fumi, you're about to leave, so can you answer this question before you go? Hello, Fumi. Thank you so much for sharing. I'm a research recruitment manager for NIHR BioResource, and I'm delivering a program called Improving Black Health Outcomes. I hear a lot from participants about trust and concerns about data, samples, etc., how they're used and stored. Did this worry you? If it did, what would, or did you want to know more and about to have enough trust in the research team?
Thank you, Doremi. Yeah, no, that's a valid question, because I know when you speak to a lot of people are concerned about trust, given sickle cell and history and inequalities and so on and so forth. I think for me, I wasn't so concerned about trust. I think for me, I guess it stemmed from the very beginning. So like my medical team, I have trust, I have faith in my medical team. They know me really well. I know them. So I think the fact that it was something that they were putting forward, I knew that it wasn't something that they had put forward to me lightly. They had gone away, they had reconsidered it. And I guess also meeting the transplant team, asking those sorts of questions, like what happens to my results, what happens to data, I was reassured that things are anonymized. No one is going to be able to trace certain results back to me. And I had, I guess, an appreciation of actually, okay, I'm kind of like just one piece of the puzzle, if that makes sense. So like, my data is needed to kind of look at the bigger picture, to kind of say, okay, this trial, this is what we found with the control group, the people who are on standard of care, this is what we found with people who aren't transplant. So I wasn't really worried about like my data, to be honest, no.
Thanks very much, Funmi. I know you've got to leave us, but on behalf of everyone here, we're immensely grateful to your participation tonight, and good luck with the trial.
Thank you. Thanks,
We've
everyone.
got.
Bye-bye.
Bye. We've got a question from Elaine in the chat, which I think is a very pertinent one. What help is available for older sickle cell patients above the age of 60, as it seems the treatments that we've discussed in research trials are mainly for younger patients? I think that's an important question, because a lot of trials do set an upper limit in terms of age. And Noémie, Stephen, would you like to comment on that and what we can do in terms of developing research that will help patients in the older age groups?
So that's a really good point, and I think there are groups within the research. Well, there are groups of patients that are, in many ways, sort of ignored in a lot of the clinical research that we do, and we need to sort of try our best to try and do something for them. So just we've been talking about redress. Just for redress, there isn't an upper limit, age limit on those patients that could be recruited to that study. It's based on how fit they are and whether they've got a match as opposed to their chronological age. But Mark is right that the vast majority of studies do have an upper age limit on which patients that could be recruited. So I think there's probably a few things just to say. I think we do need to sort of reach out, and we do this a lot, speaking to the companies that set up these studies and talk to them about trying to make the criteria that about recruiting patients a bit more sympathetic to the patient group that we look after. So a lot of the studies don't include those patients with hemoglobin SC genotype, though those patients have a great need, and there is very little for them as far as treatment options. So we do a lot of work working with the pharmaceutical companies when they set these trials up about trying to consider including patients who wouldn't usually be included in clinical trials. But it does create a challenge. I think a couple of other things I just wanted to pick up on from previous comments, just regarding trust. I think trust is a massive issue in clinical research. There's a lot of mistrust, and we need to acknowledge that. And we need to, and I think, as sort of Fumi alluded to, that the trust comes with building rapport, building relationships. And we at Imperial work really hard with our patients, with our clinical trials team, are embedded within our patient community. So when it doesn't feel like every time, the only time we come and talk to patients is when we want something. So whenever patients contribute, they get feedback on how their contribution has impacted the research that we're trying to do. I think that's really important. And then the final thing, and I know Fumi's left, is regarding the trial, because I kind of I feel for her. Just a couple of things. One, what Robert said about the haploidentical research. So the trial that redress is based around the transplant that the redress is based around. There's increasing data to suggest that this is a very effective way of curing sickle. So I suspect not too long from now, as Robert alluded to, it will likely form part of our standard of care, things we do for all our patients who are eligible. So yeah, I'll leave it there.
Noemi?
Yeah, thank you. So I think that's a really good question, Elaine. And one of the things I did want us to get into tonight is that we sometimes think about research as just these, very, very high-tech, very expensive clinical trials that really they're sort of the end step of years of research, basic science research on maybe animals in the lab, research on human tissues, all sorts of things. And then finally, we're doing this clinical trial. But I just wanted to touch on two things. One is that for us to be able to have these new approaches in the future, we also have to be doing the basic science now. And that's a lot harder, I think, for patients to understand, because it's more hidden, it's in the laboratory, and also it takes so very long. So you'll have someone working on their PhD for 3 years, and they kind of might answer a tiny little piece of the puzzle, as Fumi was saying, or maybe it was Robert, I can't remember who mentioned piece of the puzzle. But so sometimes a lot of research is happening behind the scenes, and that might be something that would then become available for older people. So what I'm trying to say is, don't lose hope because there isn't something at the moment. The other thing I wanted to say is that like Vicky mentioned, this improving Black health outcomes, there's a lot of research that is hard to understand because it's collecting lots of samples and collecting lots of clinical data from thousands and thousands of patients to start to see patterns and to sort of use statistics and maybe sometimes some genetic analysis as well to start to understand better why sickle is so different between individuals. So you've got people who live into their 70s and 80s, and you've got people who have really severe complications very early in life. And again, these research studies really need as many people as possible to join, because unless we have all those big numbers, the statistics won't show up. So that's another thing I wanted to say. And then finally, we do have other types of research, which is more qualitative research. So it's more about quality of life. It's more about how people are feeling, what symptoms they're experiencing. And so, for example, there's one study called the Rudy study, which includes sickle cell disease, and it asks patients to fill in questionnaires about fatigue and pain and things like that. And again, for a participant, it might feel like, what difference does it make to fill in these questionnaires and to get these emails and have to log in and do that? But again, until we can collect all of that data from patients all over the country, only then do we start to see patterns and say, well, actually, it looks like, at an older age, pain goes down, fatigue goes up. Maybe we should be thinking about, I don't know, I'm not going to start inventing ideas, but my point is that there's a lot more research going on than you might necessarily be aware of. And participating in these things, even if it's just a one-off sample or regular questionnaires, these really do make a difference in the long run. But I understand if you're the patient, you would rather have something that's going to help you straight away, because all of us would like to feel better. As a patient, you want an answer for you, ideally, even if you're very, generous and altruistic. It would be better if you could feel better out of it. So, yeah, I think that's it.
Thanks, Naomi. You touched on how what we would call basic research, which is often research in the laboratory, not involving patients directly, can lead on to discoveries that may have very tangible benefits for patients in terms of new treatments. And a very good case in point would be Casgevy, which is the gene editing or gene therapy treatment approved now for sickle cell, because that emanated from just such research in the laboratory. Yes, with quite a long pipeline, perhaps over 10 years, but eventually culminated in a potentially curative treatment. So I think getting that balance between basic research and applied clinical research is really, really important in terms of advancing treatments for sickle cell disease. Another comment from Elaine about hemoglobin SC and what is being done in terms of research in that area. And I think it is fair to say that a lot of the clinical trials, particularly of new drugs, have focused initially, at least, on people with the so-called more severe clinical forms of sickle cell disease, like SS and S-beta-0 thalassemia. So what can we do to try and improve outcomes for people with hemoglobin SC?
I think there's a couple of things. Sort of going back to the point, we need to make it clear, because there's this assumption or this suggestion that the SSs and S-beta thalassemias are the more severe, that have more severe disease. And in the main, that is the case. But all of us that look after patients with sickle cell, I'm sure there's some SC patients, and I think Elaine is one of them, have severe complications of disease. And we just need to try and do better for them. And I've been in several discussions with some of the pharmaceutical companies, and I think they, unfortunately, a lot of them don't really get that point. So it's a point of education for them more than anything, so that they try and include SC patients in the trials. And I know that some of the drug companies are starting to do that. So if we can just try and do our best to try and educate them, then it makes it slightly easier for those trials to start to include patients with hemoglobin SC who sometimes do have quite limiting complications. Yeah, so I think that's an important element, and also, and Naomi spoke about it quite eloquently, but I think it's really, really important that we collect that data, because unless we can tell, me telling people from my experience of looking after patients with SC, or an SC patient telling the drug companies, the commissioners, the various other people who are important in some of this decision making, but collecting that data so that we can show them irrefutably that this is a problem, I think is equally important. So yeah, so if someone asks you to do a questionnaire, it may not be as exciting, not maybe as beneficial to you, but it does carry weight. It does have benefits. So it's really, really important.
Thanks, Stephen. Naomi.
If I may ask Robert a question, if that's okay, if you don't feel put on the spot. So I do a lot of what's called PPI, which is patient and public involvement in research. So this is about how we involve patients in research. And obviously the trial you've joined is already all set up. So, you know, asking you your opinion of how the trial should be isn't really going to change anything. But I just wonder, as a patient going into a trial like this, where it's about having a potentially curative treatment, but being aware that there might be some complications or lifelong effects, like what would you say is important to you that the trial addresses? Because sometimes a lot of these, like the drug companies or the scientific group that organizes a trial, they will use very sort of traditional outcomes. So they'll say, what we want to measure is how many more people are alive, or how many or like people's hemoglobin levels, things like that. But when you speak to patients as part of this patient involvement, you realize there's other things that they wish the trial was actually trying to answer. Stephen, did you want to come in before Robert or after? After. Robert.
I'll try and get this. So, okay, so how, when it comes to the trial addressing, I feel like they did, it's different stages. So at the beginning, it was a lot of information, and you're trying to take in a lot of information, which so at the beginning it's quite, I wouldn't say daunting. You have to try to get to grips with it, for me. And again, there was the questions, again, like I said at the beginning, the main questions I had at the beginning was, again, aftercare at home. What am I looking out for at home? And those things. And is it going to improve, not necessarily the crisis? Yes, that's one aspect, but sickle cell is more than pain. Pain's only one aspect of the illness, especially when you're dealing at home on a day-to-day. So you're talking about the tiredness, fatigue. Are we talking about the aches or those little morning things? Again, age isn't going to help that as well either. But I guess that was one set of questions I did have, and wasn't sure whether or not it's going to answer that. And I don't know if there is an answer for that. However, yeah, so at the beginning of the trial, it was a lot of information, so overload. So you're trying to take in, and I think everyone does this. When you hear anything new, or when you're listening to something, you're seeing on how it's going to affect you the most. But because of the quantity of information, it was quite difficult to try to put that into real life terms for people, for me particularly. And then second of all, I'd say communication. So communication is a big one, in the sense that I understand that the trial, it was already, like you said, it was set up how it was always going to be like this. So I'm trying to come into their world. However, when it came to trying to find out exactly what they're looking for, what's needed, what participation, how much effort does it take on the patient as well as as well as the trial team. I felt that it was a bit of a grey area, because it's like you only know what's happening next. So they give you one appointment at a time. So you go in, okay, this is it. You're looking at a lung function test today. Sometimes it's not necessarily clear always how what the breakdown, how it all builds into one bigger picture, if that makes sense. That was my main thing. It was just trying to understand how, what is the lasting effects? What are they looking at now that's going to try to mitigate the effects, or know what they're looking for further down the road? As I guess you try to picture it, right? You try to understand what's going to happen to me exactly, and is it going to mean, especially when you're first applying for the trial, you're figuring out whether or not am I healthy enough to partake in the trial. And again, and where I'm at now, I guess it's just understanding how this could potentially help others to come. Yeah. And what I think, I won't say our goals are different, because our goals are very similar. Mm-hmm. However, my goal is trying to do the best for me and try to improve my health condition. But I don't know how. Is it just me doing amazing that's going to help it? I'm doing great, and hopefully the results coming in that's going to affect the people coming behind me, or is it that there's things that they learn along with my process that's going to help the people that's coming behind? So I don't know if that quite answered your question.
Yeah, that's really interesting. Thank you.
But yeah, it was difficult. It was tough. I think it was at the beginning. It was tough. Now I get a little bit better. I understand a little bit more.
So I just wanted to check. My hand came up really quickly because I think that's something that I've been thinking about a lot. As a team, we've considered this quite, because as you said, Noemi, the trial was designed, and I mean that we couldn't do much to change things. But I think, has been mentioned multiple times, is the meetings. So we've had, I don't know how many meetings I had with Robert before he decided, and we have multiple meetings with all of the patients, and try and give them much time to digest as much of the information as possible, and also making sure that information is delivered them in different ways. We know that people sort of absorb info in different ways, and if you can give them some written information, there are some websites with videos and various other things where they can sort of try and digest the information in a slightly different way. And also, I think probably most importantly is peer support. So we've got some patients who have had a transplant who very altruistically give their time. We set up a patient group where patients of different stages of the transplant, some who are over a year out, some who haven't had their transplant yet, and they support each other. I think that's probably the thing that's probably most, well, Robert can speak for himself, but from speaking to patients.
Definitely, that's helped a lot. Again, and it's funny because at the beginning, it wasn't necessarily feel alone, but because you don't know, I don't necessarily want to be not unkind to people, but especially when I've been approved for something, right? And it's something that not necessarily that people knew about, but when they find out, it's like, so you don't want to you don't want to talk to the wrong person or say the wrong thing to the wrong person. So that group has been great in the sense that we all are happy for each other. We're all willing each other on, and because we're at different stages, I feel like it's a bit each one teach one. So the person who knows a little bit, who's gone through that stage, can then pass it on to someone else. So I definitely feel that going forward with the trial, or in this specifically, it would definitely help if that could be attached to along with the trial. So not just in Hammersmith Hospital, but along the way with everyone in all the hospitals that take on and do the hablo stem cell transplant, or stem cell transplant as a whole, because yeah, it's the amount of valuable things, and it's the smallest bit of information. It's something that you may not even think. You think it's common sense or something, it's straightforward, but it's not. So those groups are very helpful, not only for support, but for knowledge and to understand that you're not alone going through this, and no question is a stupid question. That's definitely one thing. Another thing as well I picked up.
And then one more final quick thing I wanted to say, sort of, we've made the point that this trial was set up and we can do much about it. But I think having patients involved in trial design from inception, rather than sort of as a performative thing once the trial's already sort of really is so important. Because as Robert said, there are things that I wouldn't ever consider, but are really important to patients. And I think we really need to have them, and that helps build the trust. Because if they're involved in the decision making, they're involved in the way in which a trial is sort of designed, they're more likely to engage with the study. So I think having patients involved in these sorts of things from the beginning so they can contribute to make the trial better, I think is really, really important.
Yeah, I couldn't agree more, Stephen. And I think that would also go some way towards answering Elaine's questions about age group. Now, sometimes having patients involved, like if you say, well, what if patients were involved in setting up the redress trial and they said, well, we'd like to include patients over 60, that it's not because the patients want to do that we can just do it. So there'll be like biological reasons why that being over 60 would just be too dangerous to have this particular treatment. But in another trial, maybe it's the people who are preparing the trial would think, well, actually, yeah, we hadn't thought about going over 60. We could do that, or including SC or including other subtypes. So definitely by including patients, it makes the trial better, more relevant, and answers questions that are important to patients.
Thanks, Naomi and Stephen. I'm just looking to see if we've got any other questions in the chat or Q&A. Can I ask a question to those people on the call? How many of you have participated in research of some form, either a clinical trial or an observational study? If you have, could you react with a thumbs up sign so we can see? Yeah, so a relatively small number of the people on the call have participated in trials. And can I ask another question, which is, of those people on the call, how many have been approached about participating in a clinical trial? So one or two additional people have been approached, but perhaps not chosen to participate. But it's still relatively small number.
Yeah, it's not huge numbers at all, is it?
So is there something about our raising awareness about research in sickle cell and what opportunities that may present for patients?
I guess it also depends. Oh, I was going to say it probably depends also where people live. So because I'm based in Oxford, we don't have as many patients as the London centres. We often don't get approached about trials because we might have only a couple of people who would be eligible. So from the point of view of the trial organisers, they think, well, it's not really worth opening the trial in Oxford. And I think that's probably true all around the country. Although there's probably other places where there's a lot of patients, but sometimes there's not the capacity, is it, to open the trial? So
I think your point is, I think part of the answer, to be honest. I think there is, because I mean, obviously I'm based in London, but even within London, even within sort of our region in Northwest London, there are pockets that get access to patients who get access to clinical trials. And there are a significant portion of patients who need them, but don't have access. I think there is very much an issue with sort of trial equality or research equality and patients being able to access things that actually will do them benefit. People who are willing, who want to get involved in clinical trials should be able to do so. And I think there is a piece of work that we need to do about how to try and increase the equity and access to clinical trials to all patients that want to. And I think that it's part of the fact, and one of the main reasons that it's an issue is that often these trials are sort of focused around big centres where there were a lot of patients, as you sort of alluded to, but also the teaching hospitals, which often are sort of the focuses for these trials. And I'm always struck. I sit in clinic, I feel like we're doing a great job about encouraging people and sort of telling people about what trials we have open. Patients tell me that they don't think about them. So we aren't doing as much as we can with communication. We do need to do more and trying to make it more visible so patients can find out themselves where the trials are and they can sort of reach out, but also enabling them so they can go to their healthcare professionals and say, actually, what's available to me here? And if they don't have anything immediately available to them in their region, can you send me someone else who may be able to help me? Patients will travel.
So, Stephen, just being devil's advocate, you hold a position in the NIHR as a specialty lead in hematology. What can the NIHR do to try and improve that equity of access to clinical trials?
Yeah, I think to be fair, they're doing quite a lot at the moment. I think so. The sort of education, I think, is the cornerstone to a lot of what we do. So people being understanding what clinical trials are, understanding where those clinical trials are available, but supporting the teams on the ground, giving us the support, the time, the resource, so that they can set up these studies. Unfortunately, they're very labor intensive, understandably, because these things are very specialist and you want them to be done well so that patients have the best outcomes and we can collect the data so it's of value. But all of that takes resources. So, and I have these conversations not infrequently with the NIHR, that there needs to be the resource to support the setup of these studies, that the teams that need to do the work to collect the data need to be supported in all of those things. And the hope is that there is an incentive for us to do this, to do it for various reasons. And I think the hope is that if we start to do that more regularly, it will build up that trust within the community that clinical research just comes part of standard of good, basically comes part of good quality healthcare, that you think about a clinical trial at every stage of what you're doing.
Thanks. So can I bring in Marilyn Roberts-Herwood?
I don't think they can speak.
Yeah, I don't think the
We have-
participants can unmute.
Right.
Marilyn,
right.
maybe type in the chat.
Is it possible to put a comment in the chat? I think there was another comment as well from.
Can you hear me now?
Yeah.
Excellent. This has been really interesting, actually, and I know that we have a site with a lot of patients, and a number of them increasingly now are interested in participating in research, although there has been a lot of hesitancy for historical reasons, but they are now interested, or some of them are interested. A number of people say to me, why now? Why now are they interested in improving Black health outcomes, for example, etc.? So there's a bit of hesitancy, but not total reluctance. Certainly in terms of our pediatric population, parents are grabbing at it because the thought that they can improve their children's outcomes, etc., they love it, and they're really, really interested and adopting. And as I said, for the adults, there's a bit of hesitancy there. I think our biggest problem in the adult for the adult population is we do not have the research staff available to conduct this. And I don't know if these studies come with that support.
Thanks, Marilyn. I think the delivery of clinical trials is obviously very labor intensive. I guess we are quite fortunate in London in that many of the the major clinical trials in sickle cell have been set up in one or more London centres, and given the geography, it's reasonably easy for patients to access those. Much harder for patients outside of London, probably. Naomi.
Yeah, I think sort of to take up what Marilyn's just said, as well as what Stephen was saying about funding. So we have a huge problem with funding, and we don't have a research nurse. So whenever we are approached about studies, if it doesn't come with the funding for the research nurse, we can't open it. And one of the issues is that sometimes there'll be a study like an NIHR study that will say, yes, you can access NIHR funding for this, but it will often be a small amount of funding, and there's something about it has to be used before the end of financial year, and that makes it impossible to hire anybody, because you can't just in the middle of the year put out an advert to hire somebody for a few months, and especially because these are not full-time positions. So sometimes I think it's disingenuous that whoever's funding it says there is money available, because it's not money that we can actually use in the realities of the NHS. And I think what we're all saying is that it's really important for research to become a true part of the standard of care that we deliver. It's important for that infrastructure to genuinely be invested in. Otherwise, it's just lip service, and only the big centers will be able to do it that have got that capacity. That means even if a study doesn't have enough funding for the research nurses, they can use research nurses from another study to carry this out.
Thanks. Would anyone else like to ask a question in the chat or in person? So I think those are all the questions that we've had. Can I ask Stephen, Robert, and Naomi whether they would like to just say any final words, and what we might do to try and support the development of research for patient benefit in sickle cell?
I guess I would just say thank you to everybody for coming, because the fact that there's 30-odd people on a Monday evening when they could be doing something else with their time is really encouraging. Just, I would say for people to keep asking questions, ask their clinicians what's available, and ask how you can get involved, even if it's not something as kind of heroic as what Robert is doing. There's lots of other ways of getting involved, and it's always very welcome when people are interested.
Yeah, no, thank you. I appreciate that. I think that things like even meetings like today are one way so people get some knowledge. And I feel like we have to keep asking questions. I know it's sometimes quite difficult when there's a lot going on with everybody. Everybody's got to live their life, but at the same time, yeah, you've got to be as inquisitive and ask questions. And hopefully, if we keep going, we keep asking questions, and eventually, these have to be taken somewhere. They have to be answered eventually, hopefully, because yeah, it's really important. And just from my recent close experience with the research, it's amazing. So I'm definitely gonna advocate. I tell everyone to sign up and try to take part as much as you can. And even if it's the smallest thing, you never know how much it can change something. And it may not be straight away, may not be next week, next year, next month, next year, but you could do something. But yeah, thank you guys. And I appreciate everyone on this call. Thank you.
Just a couple of quick points. So just to echo all that's been said, but just to add that I think that we're in a position, to just go back to sort of Marilyn's point, why now, why sickle? I think there's been a lot of interest in sickle more recently, I think that interest, unfortunately, probably won't be there forever. So we need to ride that wave. We really do need to sort of push the agenda for sickle forward. It's the fastest growing genetic disorder worldwide. It affects a significant amount of individuals, but communities as well. So we need to do better for sickle. And I think the way to do that is through research, understanding the disease better, developing effective, safe treatments for patients with the disorder, and building that trust. Sort of again, going back to what Marilyn says, there is a lot of mistrust. There's a lot of people who do think that what is being done is not being done in their interest, and we need to work hard within the community to try and dispel some of those concerns. And you only do that by embedding yourself within the communities and working with people so that they understand what your agendas are. And we really do need to work hard on that. Yeah. So thank you so much for coming today. It's been really, really a really entertaining discussion. Thank you.
Thanks. Well, thanks to all the speakers, to Funmi, Robert, Stephen and Naomi for their contributions tonight, and thanks to the NIHR for hosting this webinar. I hope it will be the first of several, and we'll have an opportunity to discuss the progress of research in sickle and hopefully see coming from that improvements for patients. So thank you all for joining tonight, and we'll say goodbye.
Thank you, everybody. Bye-bye.
Thank you. Bye-bye.
Thanks a lot.